The second most important title that we have today is a major organ involvement in Behcet disease. Yes, it is a rare disease, but we are facing a hard time in management. I believe that Dr. Behcet Maghlooth will cover this point, the major organ involvement Behcet disease. Dr. Ibrahim, as all of us know, is the Assistant Professor of Hematology Unit, Department of Medicine, College of Medicine, King Saud University, Assistant Director of College of Medicine Research Center, King Saud University, Director of Research Registries Database, King Saud University, Principal Investigator of the National Prospective Cohort of SLE in Saudi Arabia. Most welcome, Dr. Ibrahim.
يعطيكم العافية. It's always hard to talk after Ro'a. MashaAllah, she's well spoken, full of knowledge, and she has tons of information. So I'm not sure I'm going to be able to do the same, but I will do my best to cover this important topic. What is very important that I want to share with you is that we will share a lot of data. Some of these are published and some of these are not. So I hope that we can have a nice journey through this talk. Okay, well, we don't have any specific disclosure for this topic, though we get grants and funds for everyone who's willing to pay and support educational activities, so we're more than happy to do that in KSU. Okay, so this is my outline. We'll cover, so I think most of us and no rheumatologists will graduate, especially from a region where Behcet disease is a common disease, without knowing some important information about the organ manifestation in Behcet disease. However, we'll try to compare what we know about Behcet disease from the literature and from the demographic presentation in Saudi Arabia. We'll try to address a couple of very important points related to why do we need to know about Behcet disease organ manifestation, and hopefully going to be able to convince you that knowing organ manifestation in Behcet disease has more to it than just diagnosing the patients. Okay, so of course we know the major organ involvement and different organ manifestation in patients with Behcet disease. We understand that the most common presentation is oral ulcer, followed by occasionally genital ulcers and skin rash. The form of skin rash varies according to the different classification criteria, whether posteopopular or other different types of rash, which are very common in patients with Behcet disease. In addition, they share Kopner phenomena, where trauma can induce neutrophilic aggregation around the vessel, and that can result in positive pathology tests. They also tend to have obviously it's a vasculitis with the various vessels involvement, and consequently they tend to involve vessels, and the involvement of vessels usually manifests itself in the form of either venous thrombosis, arterial to lesser extent, and also development of aneurysms. In addition, the disease can and will, in many patients, present in the form of uveitis, which is involvement of the eye, depending on different sites. Majority of patients with Behcet disease will have panuveitis. However, various forms of uveitis has also been reported in Behcet disease. And this is very important presentation because we tend to see it more often in patients with Arab descent and people from North Africa compared to Caucasian population. In addition, the disease obviously has the tendency to involve major organs such as the CNS system in different ways, including either stroke formation and vessels involvement, such as the picture here down with venous central sagittal vein thrombosis, or the classical parenchymal involvement in which they mimic demyelinating diseases, and with a classical pattern involving the brainstem area. Finally, GI manifestation is a very important part of the organ manifestation in patients with Behcet disease, and particularly this tends to be increased more, or we believe that it is increased more in patients from North America or Caucasian population compared to other classical presentation of Behcet in the Mediterranean region and Silk Road. Now, well, I think this part of the information you all know about. But what about in Saudi Arabia? Now, unfortunately, we have only 2 studies in Saudi Arabia, though we tend to see a lot of Behcet disease, about the different presentation. Both studies are cross-sectional study. One of these studies has been presented here in the conference in the abstract from the group in the southern area. You can see here in the first study, it was the famous Dr. Al-Dhal'an study, which was reported in the 1997 and involved 46 patients coming from different centers, including King Saud and from King Faisal Specialist Hospital, where they described classical presentation of oral ulcers followed by genital ulcers. And you can see that the ocular involvement is high in this group of patients. In the later study, which was published just this year, report patients with Behcet disease from the southern area. And in this study, you can see that the involvement or oral ulcers is slightly less. The ocular manifestation is slightly less. However, they are predominantly enriched with vascular manifestation. Now, this is very important because the question is, first of all, why do we have such variation? Because this disease is very interesting, we conducted a cohort study at King Saud University Medical City of patients with Behcet disease who meets classification criteria. Now, we will not go to the details of classification criteria, but there are 2 most common classification criteria that are used in Behcet disease. The International Study Group of Behcet, in which the requirement for oral ulcer involvement is important for the patient to meet the classification criteria. And hence, in all the cohorts that you will see using this criteria, all patients, you will have 100% involvement of oral ulcers. However, it has been criticized by the limited sensitivity, and hence the patient have been another effort in 2006 developed through a similar multi-center group, and that group develop another criteria, which is an international criteria of Behcet disease, which we use in this particular study, which use a point system, so weighted system, in order to make the diagnosis of Behcet. Tend to have more sensitivity. What is very interesting, we have 134 complete classified patients with Behcet disease. Those patients tend to be younger age, so the demographic part is similar to general population. I want to highlight that we have a decent distribution between Saudis and non-Saudis, but more importantly, the percentage of smokers. So we tend to have about 40 or 45% of the patient being smoker, which might be slightly higher than what we see on average Behcet reports in different cohorts, except the Turkey ones. In addition, you can see the average disease duration. So this is a prevalent cohort, so everyone who's diagnosed with Behcet. The average disease duration is about 5 years. And what is very important, and I want to highlight this part, is the family history. So we tend, as rheumatologists, to believe that patients with rheumatic diseases tend to have positive. The importance of family history is very valid, because we believe that when someone has a family history, then this might be a risk. In contrary, in patients with Behcet, the presence of family history doesn't seem to increase the risk of Behcet disease. And this is very important, because this has been shown in our study, in addition to previous studies in which family history doesn't increase your risk of Behcet disease. However, what is very important, that we see familial aggregation of patients looking like Behcet. And this is very important with the recent publication in terms of the mimicker of Behcet, including NF-kappa B mutation or the haplotype insufficiency, which are a group of people who tend to have similar presentation with mucosal ulcers, skin involvement, and or infection. Now, without further detail, these 2 graphs highlight the current characteristics of patients with Behcet from our cohort. And what I would like to highlight on the left side is the initial complaint. So you will see that the cumulative complaint. So you'll see in our cohort, it is enriched with patients with ocular manifestation. So you'll see that although the most common frequent symptoms is oral ulcer, as you would expect, the frequency of that is slightly less compared to the other publication. However, the most common complaint to our center is usually in the form of uveitis, which tend to be the main reason of their referral. So we catch patients with Behcet disease at the stage of uveitis. That highlights a very important point, that we are missing a lot of patients with Behcet early on, when they present with the mild symptoms. And that means probably that most of our studies tend to be skewed into more severe phenotype rather than the general simple oral ulcers and maybe a genital ulcer here and there and skin rash. Now, the second question, is this variation related to a disease? So is the disease actually, does the disease varies according to the ethnic background or geographical distribution, or this is just a result of a sampling error, so i.e. single-centered reporting a single study, or the way you sample, the way you report patients based on your classification criteria? This is a systematic review that was published by Lewis in 2007 trying to address this. And what I want to highlight here, these are major cohorts of Behcet disease that report different presentation, incidence, and prevalence. You will see the numbers are small, but the reason being is the quality of the paper. So in this systematic review, they stuck to high quality, medium to high quality paper. And what you can see that the quality of papers, majority of them were not as good, and they are subjected of bias. Hence, the systematic review concluded that it is very difficult to confirm whether heterogeneity exists through geographical distribution, or this is just a matter of a sampling error. But we tend to see really a variation across different regions. This is a recent paper that addressed different cohorts reported until now with patients with Behcet disease with various organ involvement. And I want to highlight that the variation in terms of major manifestation exists, particularly when you go from the east to the west. You will notice that the GI manifestation, for example, tend to be highest in the European ancestry, so in Europe, to a lesser extent in Asia, and then maybe increase a little bit in the North American and United States reports. However, we do not see the same thing in our population. In North America, North Africa, and Arab distribution, you will see that more ocular involvement exists across these cohorts. Now, why do we care? صراحة يعني اليوم سبت, and we are really leaving everything behind to talk about different presentation of Behcet disease. I hope this case help you with to address the first part of why do we care. This is a 28 years old gentleman who is originated from Sudan, came with completed a course of latent TB treatment, presented with classic presentation of oral ulcer, genital ulcer, that we thought that he has Behcet disease. Later, throughout his presentation after colchicine treatment, he started to notice fever. And the fever episodes start to be more often associated with chest pain and shortness of breath. Later, the patient was found to have pericarditis and some pericardial effusion. After thorough investigation, the patient was not found to have any other secondary causes, so the decision was to put him on higher steroid dose and switch him to anti-TNF. Initially, he did great, and after a month of steroid taper, the patient started to have the same fever and pericardial effusion again. So the question is this presentation a form of Behcet presentation? Now, going back to the fact that we wanted to know to the reason of this presentation, which is organ manifestation. In the importance of organ manifestation, recognition of organ manifestation is first a capability to diagnose the patient and unusual presentation. So the question is serositis a usual presentation of patient with Behcet disease, or could it happen in patient with Behcet disease, or this is most likely to be a secondary cause? Surprisingly, we looked at the literature and we had no evidence to support that. So we conducted a study that was presented in this from my students in the conference, where we did a systematic review looking at all three major databases, Cochrane, Embase, and PubMed. At all cases, confirmed Behcet based on classification criteria, whether ISG or Icbd, who presented with serositis. In this systematic review, we try to look at the we try to look at all reported literature, including case reports, case series, cohort, and clinical trials. As you know, the Icbd international classification criteria, this is just a reminder, in this criteria you do not see the unusual presentation. So this is the first part. The most important part about the organ manifestation is to recognize whether this fits the classical presentation or this is unusual. So this is the PRISMA chart. We looked at a 514 paper, and at the end we included about 56 paper, of which about 44 patients were case reports, so detailed case reports. So this is a population-based systematic review or patient-centered systematic review. It's one of the stronger kind of systematic review because it gives you ability to create a cohort of rare presentation. And this is what we did. So this cohort is composed of 44 patients who meets classification criteria of Behcet disease, predominantly male, so nothing out of usual. Majority had oral ulcers, but you can see, and then genital ulcers, and you can see the ocular manifestation fits within the general distribution of Behcet, about 1/3 of the patient. What is very important in this part, we tried to look at the features that is more likely to be associated with psoriasis. So that is question number one. Is there any feature that tend to be more often? Because the sample size is not huge, the ability to detect that may not be high, so forget about the p-value. What tend to be to increase risk is two important features, particularly the gastrointestinal involvement, and two, the constitutional symptoms. So constitutional symptoms tends to be more likely to occur in those patients with psoriasis compared to the general population. But then you will say, well, you did not answer your question. Is that related to the disease or really related to secondary cause? So this is the distribution of the causality or attributed causality. So in 68% of the cases, the causes was Behcet disease after a thorough investigation of secondary causes. And that can be seen in the paper itself, hopefully later, through the qualitative assessment. However, about 25% of the patients still have secondary causes. And the distribution of secondary causes can be seen here. TB is one of the largest risk, in addition to other genetic variants or mimickers. For our pediatric group, we know that familial Mediterranean fever is a mimicker. Now NF-kappa B and haplotype insufficiencies are other mimickers. And also other diseases that share common immunological background, so that's inflammatory bowel disease or inflammatory bowel disease related etiologies or medication related. Now, what about the outcomes of those patients? This is a very important part because in the cohort, the mortality was about 10%. And this is very high mortality, that highlighting the importance of Behcet disease. It seems that it took a lot of time. Okay, so first we need to recognize the importance of organ manifestation, allow us to recognize classical and unclassical presentation. But what about prognostic factor? This is a study that we conducted, also presented, and the students won the third prize for oral presentation, where we looked at the natural history of Behcet disease. This is the first study that addressed how Behcet disease varies across time. I.e., we don't look at cross-sectional point. We want to see how the disease varies over time and what factors influence such change over time. And to make the story short, without going into the details of statistical modeling, the organ manifestation, so underlying organ manifestation, tend to predict how the patient will behave over time. In another way, patients who have mucosal involvement, particularly oral ulcers, are the ones who are more likely to have persistent disease over time. So that's very important for you as a clinician on treatment, because you know in advance that those people will likely require treatment for a long period of time. And it is important to address that to the patient, that their disease manifestation will not necessarily completely disappear over time. In contrary, patients with major organ involvement, particularly CNS or vascular involvement, tend to have a peak presentation at the beginning, and then they settle down over time. So, and some of us notice that through their clinical experience. So why this is important? Because you can reassure the patient that likely you're going to be able to taper their medication off over time, and they are likely to be settled over time. So it's a storm, and then it settles over time. It is also important to mention that when patients have persistent oral ulcer, try not to judge their disease activity based on the oral ulcer, and this is important for those who use disease activity measures such as Behcet disease activity index. because it does include oral ulcers and genital ulcers in the calculation. So that would raise the score and unlikely to give you a reflection, a true reflection of other major involvement. Now, I know I'm running out of time. In the same paper, we noticed, we looked at the use of medications, and you can see that patients who have higher disease activity at the beginning, likely to have persistent disease activity over time. Those people are more likely to use steroid, but what is very interesting out of this paper was actually, hopefully soon, was actually the impact of the addition of anti-TNF. So the addition of anti-TNF in those with high steroid use, those with higher organ involvement at the beginning, tend to have a synergistic effect that allows you to taper steroid off over time compared to conventional disease-modifying drugs. So when someone comes with high disease activity index, multiple organ involvements at the beginning, it may not be a bad idea to consider the use of anti-TNF in addition to steroid compared to conventional disease-modifying drugs, including cyclophosphamide, because we did not see this steroid tapering or this additional effect with the conventional disease-modifying drugs. Obviously, some data in the literature reported, but I'm not going into that. I'm running out of time, but the last part of the question is, can the type of organ involvement predict other organ involvement? So if I know what kind of organ do you have, can I predict, for example, CNS manifestation or not? There are a lot of heterogeneity in the literature and various reports that try to dissect patient with organ manifestation with Behcet into different clusters and different phenotype in order to understand when someone has a presentation whether they're going to be at risk of other presentation. This is a very nice paper that looks at neuro-Behcet, and we can see in this paper that the presence of eye involvement tend to have increased risk. Eye involvement in another paper by Chang, which was a population-based study, tend to increase to predict a risk of acute coronary syndrome or MI in patients with Behcet disease, which some of them are at higher risk compared to the patient who did not have that. After adjustment of all other confounder, I want to highlight in this multivariate analysis that other traditional risk factors such as dyslipidemia and hypertension also are more important than just the organ, but it also tells you that development of other major complication is not just a simple thing, but likely to be a multifactorial. So recognizing an underlying organ involvement will help you do a couple of things. First of all, it will help you understand different phenotype. This is one of the nice papers that allow clustering of different phenotype within Behcet, eye involvement versus mucocutaneous versus joint versus gastrointestinal. Yet, we need to understand what will happen to those people over time. Do they behave significantly different or not? But it is very important to notice that this carries its own risk in terms of association with other organ involvement. I'm not going to go into the tons of details, but this is another example where you know that cardiovascular involvement tend to be higher in people with CNS and vice versa. So when you have someone with CNS Behcet, think about pulmonary involvement and cardiovascular involvement. Now, with this in mind, I want to conclude with the following point. Organ involvement in Behcet disease is not just a presentation of how people present with Behcet. Of course, it goes beyond this. One, it helps you make a diagnosis of Behcet. Two, it also help you think about the classical and unclassical presentation of Behcet disease. Three, it does carry its own risk in terms of prediction of disease activity over time, and addition to help you predict what other organs you need to screen for or think about in the near future. And finally, it might have a major importance in terms of the prediction of complication in the future. With that, I would like to thank all the teamwork. This is a work of a lot of groups, including my students, both groups, Lama and Nawaf group, in addition to our colleague at KSU. Some of them are here, عمير وأبو سعود عبد العزيز الخلف والدكتور محمد الداوي، بروف العرفج اثنين، ودكتور سلطان المقارن، دكتور إيمان قطاس. مرة صعب الواحد، هذا زي الأوسكار لما الواحد يطلع ولازم يقول كل الناس مرة واحدة. But I also would like to thank the College of Medicine and you for giving me the opportunity to present our work.